Bismillah ar-Rahman ar-Rahim. It's a great honor and pleasure to be with you today. I come today with a new hope for cancer pancreas patient. Um, at the beginning, we have some sad reality, like that the number of new cases of pancreatic cancer is about 12 per 100,000 every year, and the number of deaths is about 11. So almost all the patients die. That's the bad news. The other thing that is the rate is growing, is up. It increased by about 1% every year for the last 10 years. And the 5-year survival rate is less than 10%. Cancer pancreas will become the second leading cause of death by 2030. The pancreatic cancer as a clinical challenge, it is a late advanced presentation, vague symptoms, imaging modality not accurate, no adequate screening modality, which is a big problem with the rapid rate of tumor growth. The recurrence is high after surgery. Conventional therapy is not good. And the predictor or the biomarker to guide treatment is not okay. Again, the patient present, almost all the patient presented more than 80% in a late stage is unresectable. The Irish saying is that the only cure for love is marriage. And I think this woman is cured from love after that. But the medicine say the only cure for cancer pancreas is only surgery. It is the only cure for cancer pancreas. But unfortunately, for 100 patients, if we diagnose today 100 patients with cancer pancreas, only 20 patients will scheduled for resection. The other 40 locally irresectable, and the other 40 is distant metastasis. Even the 20 patients which is scheduled for resection, 7 of them will, after opening it in the OR, in the operating room, it will close again because it is locally irresectable during surgery. And only 13 patients will be resectable. Again, those 13 patients, only 7 will be cured, and the other patient we have they will have a recurrence and complication after surgery. So we definitely need for screening for cancer pancreas to save these souls. Till now, we have no effective screening test for cancer pancreas in general population. For screening, we need the screening to be safe, reliable, yielding, cost-effective, acceptable, valid. All these things must be applied for good screening. But unfortunately, the screening also is a significant harm to the non-diseased individual rather than the benefit of detecting of a new cancer patient, because the modality of investigation will harm the normal person. So we think, why we screen for the patient who will be or who susceptible for the cancer pancreas, like hereditary familial disease, like hereditary autosomal or hereditary familial non-autosomal disease, or Betz-Jeger syndrome, or hereditary pancreatitis, or the early symptoms, the patient who has early symptoms of cancer pancreas, like depression, back pain, fatigue, diabetes, unexplained weight loss, or the patient with newly onset diabetes at a higher age, above 50, which carry the risk about 10 times susceptible for developing cancer pancreas rather than other patients. We found that in the first degree relative of the cancer pancreas, it carries a risk of 6% more than normal population. If the patient has two first degree relatives, the risk increased to 12. If has three first degree relative with cancer pancreas, the risk increase up to 40%. And with a specific syndrome like Betz-Jeghers, familiar pancreatitis, it may be 130 or 32-fold in comparison with general population. The method for pancreatic cancer screening by imaging mainly like MRI or endoscopic ultrasound, or alteration between MRI and EUS. Some blood work, CA19-9 is not recommended. Now, a few years ago, they start a very promising test with the pancreatic cancer detection test, which combine 8 biomarker plus CA19-9 and enter all the data in machine learning algorithm. It gives a very high sensitivity and specificity for detecting cancer pancreas, which is a new hope in detection, on early detection of cancer pancreas. But the patient who ask for that, which is the susceptible, only 10% of the all cancer pancreas. And still the remaining 90% is a sporadic case, have no familial predisposition, has no inherited cancer syndrome. So the 90% of the cancer patient which we diagnose is not have any history of this familial or hereditary disease. So still the much more patient come from a normal person without any history. So we must search for another way. Another way, we need another to change the vision of our vision on detection, change our mind. So they think that we must change the method of medicine from the start. Historically, we depend on the clinical diagnosis and treatment on experience and observation. Till the second half of the 20th century, we start to randomize the clinical trial. After that, in the late 20th century, we depend on the evidence-based medicine, depend on clinical experience, best research evidence, and the patient value. Combining all of that, we depend on the evidence-based on diagnosis and treatment. Like that, if we have 25 patients, we give them, all of them, drugs or treatment according to evidence-based. And if we have about 70 or 75 or 80% cure, this drug is valid and applied for all the patients with that disease. But what about the patient which not cured? I think they will not be happy, because if we have 15% or 20% of the patient not cured after treatment, according to evidence-based, I think they will not be satisfied. That's why our aim is to make an accurate diagnosis and to provide a targeted therapy to achieve 100 cure rate. That's our aim. We don't aim to cure some patient and the other not cured. So our aim, our great aim for all this time is to cure all the patient. And we hope that by precision medicine, which developed in 10 years ago, in 2010, to achieve that. What is precision medicine? Precision medicine, it is an approach for the disease prevention and treatment, which take into account individual difference in genetic, lifestyle, and environment. So we individualized according to the type of patient. Each patient has a type of prevention to prevent the cancer from the start, to detect early cancer, and to treat every patient or each patient according to his genetic background. So precision medicine program use a genetic information, which genome, which is genetic mapping of the patient, and proteomic, which is a protein producing map of the patient, to individualized health care, to improve treatment, to improve safety, and reduce the cost with time. So what is the difference between standard medicine and the precision medicine? If we have the same patient, the same number, the same type of disease, according to this difference, in standard medicine, we apply the standard clinical practice, randomized controlled trials, meta-analysis, physician experience. On the other hand, in precision medicine, we apply the genetic background of the patient, genetic mapping of the patient, the clinical data, the multi-omics integration. According to that, in a standard medicine, we give a standard single treatment for all the patient. In a precision medicine, according to genetic background, according to the environmental background, we divide the patient into group, and each group will take different treatment according to that. We aiming to 100% cure for all the type of the patient. On the other hand, in standard treatment, we found that some patient cured and some patient just improved, and some patient have no benefit and may be a hazard from the drug. So the precision medicine, it can apply and it is suitable for pancreatic cancer. Why from pancreatic cancer, pancreatic duct adenocarcinoma? As a pancreatic cancer is not a one disease. It is many subtypes. In the past 5 years, we found that it many subtyping according to the genetic background of the tumor. The pancreatic adenocarcinoma till now is 5 major types, like squamous subtypes, immunogenic subtype, and each subtype of that have another type according to genetic and the epigenetic of the tumor. So we can reach up to 45 or 48 type of pancreatic adenocarcinoma. Each of these have a specific treatment. What is our aim? Our aim to select the drug specific for that patient. If we give a drug, some patient, the drug is toxic and beneficial, some toxic and not beneficial, and some drug for that patient is not toxic and not beneficial, but we aim to drug not toxic and beneficial. How can we reach that? By genetic background of the tumor and genetic background of the patient and the environmental factor which the patient exposed to. So no more one size fits all in a healthy care, and specifically in cancer pancreas. We apply pharmacogenomic. Pharmacogenomic is the study that deal with the relationship between the genomic variation of the patient and the effect of drugs. According to pharmacokinetics of the drugs in the patient metabolism. Some drug for some patient is ultra rapid metabolizer, some normal metabolizer, some poor metabolizer. According to this metabolism, the patient will suffer. According to if it is ultra rapid metabolizer, lack of efficacy, the drug will not affect the patient and will not affect the disease. If it's poor metabolizer, the patient adverse effect will appear, and we need to know before we give the drug if the patient which group, according to which we will give the specific dose for the patient. So in a cancer pancreas, by precision medicine, we give the right drug to the right patient to improve the patient outcome. It will be done by identifying the genetic defect of the tumor DNA, and then create a hypothesis about the drug which patient need to cure, and then test this hypothesis in a preclinical model, and then give the drug. We need the help of artificial medicine with the precision medicine in cancer pancreatic management. As before we give the drug, we must evaluate and give all the data to the artificial intelligence as regard the clinical presentation, medical imaging, genetic of the tumor, molecular base, therapeutic response. And after that, we categorize the patient into group. Each group will take a different treatment according to the information output taken by the artificial intelligence. So this new personalized medicine strategy that have the potential to change the future of pancreatic cancer treatment. We need to say that pancreatic adenocarcinoma remains the biggest challenge for research and the medical community. Discovery of many subtypes and many biologic heterogeneity need individualized management for each patient. So increasing knowledge about genetic and molecular alteration in pancreatic cancer opens the door for few modality of management. Precision medicine start to translate these scientific discoveries into clinical management to improve prognosis. Before we say thank you, this lecture and more than 130 GI lecture is present in my channel, YouTube channel, Egyptian Academy for Gastroenterology Learning and Evaluation. And thank you so much.
Goodbye, goodbye.